You're the guy people call when they need a helping hand, moving furniture, unloading a truck. But lately, your shoulder's been acting up, and you're the one who's calling for help. And that's the moment you realize you can no longer shoulder the load.
The Joint and Spine Center is Cincinnati's leading destination for orthopedic care with a range of surgical and non-surgical treatments. So when a moment has the power to change the rest of your life, go to the one place with the power to change it for the better, the Christ Hospital Health Network. This changes everything.
The Pound This Podcast is brought to you by the Christ Hospital Health Network. This is the Pound This Podcast, episode 646, all about hernia with Dr. Jonathan Schilling.
I want to lose weight, but I don't know how to get started.
What should I meal prep every week?
How do I get those sweet booty gains?
Inspiration for your healthy lifestyle. The Pound This Podcast with Amanda Valentine.
Thank you so much for listening to the Pound This Podcast. I'm Amanda Valentine, and I am joined by two guests today. First, I have Dr. John Schilling from the Christ Hospital Health Network. How are you?
I'm doing great. Thanks, Amanda.
And I have Nick, who is a coworker of mine here at Cincy 360 Fitness, who's a personal trainer, who is should I say recipient? I don't know, patient of hernia surgery?
Either one, I guess.
Or is like you got an award.
Survivor. I like it.
So, Dr. Schilling, I mean, obviously we're going to be talking about hernia here. Is that your specialty at the Christ Hospital?
Yeah, I'm a general surgeon at Christ Hospital. I've been a general surgeon for almost 10 years. And one of the most common conditions I see in my practice, both in an acute setting or emergency setting and in an elective surgical setting, is the diagnosis and treatment of hernias. So it's not all that I do, but I would say at least a third of what I do on a regular basis has to do with the diagnosis and treatment of hernias.
What else do you do?
Gallbladder surgery, appendix, intestinal surgeries, things, problems dealing with the colon, the small intestine, the stomach, as well as soft tissue problems, lumps, bumps, skin cancers, lipomas, stuff like that.
A lot of robotic surgeries.
Robotic surgery, it's given a fancy name. They called it the robot when this thing was developed almost 20 years ago. Robotic surgery, in essence, can be grouped in with laparoscopic surgery, and the term I use is minimally invasive surgery. Minimally invasive surgery could either be laparoscopic or robotic, and basically it's a take where you use a different set of tools and maybe slightly different surgical techniques to repair and fix problems, including hernias, with smaller incisions. And there's some advantages to doing that. So a lot of hernia operations I do happen to be done robotically or minimally invasive.
And then, Nick, was yours a robotic surgery?
Yes, mine was also robotic.
And then I know for you, just recently having that surgery, Nick, that you were just so surprised about how many people get a hernia and need surgery.
Yeah, I mean, the number that I heard was 1 in 4. I don't know if that's right.
Is that correct, Dr. Schilling? Like 1 in 4 humans?
1 in 4 men.
Yeah, so,
men, okay.
So there's about, on a yearly basis, about 20 million hernia operations done a year worldwide, and almost 700,000 done a year in the United States. Most, 2/3 of them are probably more inguinal, and a third of them are ventral. So a ventral hernia could be something like a umbilical hernia or a belly button hernia, or like an incisional hernia where someone's had a prior operation for some abdominal problem, and then they come back later because it didn't heal properly and have a incisional hernia.
So how many women get a hernia? I mean, or is it just exclusive to men?
Right. So women have more issues with umbilical or belly button hernias than men do. I think there's a statistic out there, like 90% of women while they're pregnant actually have an umbilical hernia. Whereas mostly men have groin hernias. It's not always men, but mostly men. And that's because of how humans are designed. Humans are designed with natural weaknesses in the abdominal wall. The abdominal wall is a very complex tubular cylindrical structure of muscles and connective tissue that keep our organs in place and helps us move our abdomens and our core around. So our belly buttons, that's a remnant of the umbilical cord when we're all in utero as a fetus before we're born. That is a hole that we are born with. And then over time it closes down, but then over time again, and as I call it, natural wear and tear on the human body, that space can open back up. For groin hernias, men get these predominantly because testicles develop in the abdomen, but then descend into the scrotum after birth. And so that canal that the testicles descend should close down and seal up for most people. But over time, that canal can open back up, or you get other weaknesses or tears in the abdominal musculature and fascia that create these groin hernias. So we see this predominantly in men, but it can also happen in women.
So, Nick, let's talk about your groin for a second.
All right.
So, I kind of want to know if you're I wouldn't say common. I mean, that's broad stroke. If you're kind of like a typical patient that you would see, Dr. Schilling, how did you notice that there was a pain, or did you know it was a hernia? What was the process?
I had a pretty good idea on what it was. I had never spoke to anybody that went through that directly, but I had heard about it. And it actually started off the first couple of days, I was, just feeling a little bit of discomfort right around where I would assume that I've never had, appendicitis, but where I would imagine appendicitis would feel. So I was actually, Googling what does it feel like to have appendicitis? And that's what I was thinking at first. Mm-hmm. And then what I noticed was certain motions, opening a window or raking leaves, those types of things seemed to bother it more, and then created a different kind of pain a little bit lower down as I guess the hernia progressed or worsened, I guess. And after a while, I was almost 100% by the time I went to my general health care, and they diagnosed it probably within less than 30 seconds. Right? So,
would you say that's pretty typical, Dr. Schilling?
Yeah, it is. Most patients come, kind of having a thought I don't think something's not right. They see a bulge or they feel a pain. Those are usually the two things. Sometimes it's a bulge with pain. Sometimes it's just one or the other. But most of my patients would come through a general practitioner, seeing a patient in the office and then sending them to me with strong suspicion or accurate diagnosis of a hernia. Other people come because they have groin pain, but they're not really sure if they have a hernia or not. And the diagnosis can be a little challenging sometimes. You have to take a very thorough history. A lot of the things Nick said are things I'm asking, how long has this been? When did it start? What types of activities do you do that cause the pain? What types of things do you do to make it feel better? Because for a hernia, the pain is really, the pain you get is from when you tighten your abdominal core or you're using it. And so you're contracting your abdominal muscles. The pressure inside your abdomen increases, and then any weakness to that abdominal core will, your tissue inside your abdomen will bulge out, and that they'll go through that hole or that hernia defect, and then that hernia defect kind of squeezes the tissue and causes the pain. So you get hernias that are, prolonged standing or sitting. You'll have pain when you're lifting something heavy or coughing or sneezing or going to the bathroom. And so a lot of times that pain is very reproducible. Sometimes it's just situational, it only happens when I'm, really, in the gym lifting weights, but every other time during the day, it's fine. Other times it hurts all the time, no matter what they do. And so taking that thorough history and physical is very important, because you can usually make your diagnoses pretty quick with that. And then a physical exam knows a lot about hernias, because a hernia is almost always detected by physical exam. There's without very few exception. You can use different imaging techniques like ultrasound, CAT scans, MRIs to help assist in the diagnosis, but there's a lot of limitation with imaging. So, for the average hernia patient who's coming into my office, I don't put a lot of value in imaging studies unless the patient has kind of an atypical presentation, or, it just doesn't seem so straightforward. Or sometimes you need to use imaging adjuncts when someone's had a history of hernia repair in the past, and they think that there's something not right now, that maybe the hernia has reoccurred or there's a problem with the prior repair.
So how often do you see, though, that people putting off this sort of surgery, speaking from how my husband behaved, that you could see it popping out and he was in pain and he's just like, whatever, push it back in, just keep going back to work and lifting stuff. Like, it seems like, I don't know about Nick, it seems like you would be responsible and take care of it right away, though.
Well, yeah, I had a better scenario. I'd come across, kind of a slower period of my, my work period over the holidays. Let's just knock it out. I knew that I wasn't going to be able to be on as well as I'd wanted to be at work. And I just was like, okay, well, I usually have, the month of December at least slows down, and I'll just use that time to get that done and take a few weeks.
Yeah. See, it seems like the two different kinds of patients, of one that's him that's like proactive, and my husband that's like, duct tape it up.
Well, the way I would break it down, and seen a lot of different ways. You have three different general scenarios when it comes to hernia repairs and when you should do them. You have people who come in with an elective problem. That means, we diagnose a hernia, we figure it out, we come up with a surgical plan, and they say, okay, pull out your calendar. Let's find a good time to do this. It should be done. When should it be done? Just like Nick said, find a personal or professional downtime, an optimal time for you and your family to get this done and invest the time and energy it takes to do the recovery, because there is a period of downtime where you have to, refrain from strenuous physical activity and traveling and things like that. It's not a long period of time, but you want that time to invest in your recovery. So it's good to, I'll work with and counsel patients to help find that optimal timing for them. Then there are hernias that are urgently needed fixed. These are patients that are either coming to my office or into the emergency department where they're having a problem. They might have had this hernia for weeks, months, or years, and now it is painful all the time. They can't do anything to make it go away. That's why they came to the emergency department. The type of hernia is getting fixed probably same day, next day, something like that. And then the last category is the emergency repairs. And these are hernias that have become strangulated. And this is the kind of worst complication you can think of. It sounds bad, right? Yeah. A strangulated hernia is where you have your intestines pushing through the hernia, and then they're being strangulated. The blood supply to the intestine is being compromised. And those intestines will live for about 4 to 6 hours being strangled before there's irreversible death of that intestine.
Oh my God.
And that causes sepsis. It's a bad problem to have. So those patients have zero luxury of optimal timing or planning. They come to the emergency department and then they go right to surgery. There's, maybe within the hour, so to speak. Yes. So that percent, I don't see very many of those.
Okay, good.
I don't see very many urgent surgeries either. Mostly what I do are elective surgeries, but you do have that time frame. So when it comes time for an elective surgery, I think most, the statistics would show most people getting groin hernia repairs electively do it within the first 1 to 3 years of being diagnosed with a hernia or having symptoms of it. But almost all hernias are operated within 7 to 10 years of having that problem.
Oh my God.
So if someone's like, I got a hernia, it doesn't bother me much, I'm going to wait and do whatever. I don't want to handle it, and they'll probably be back for a repair.
Would you recommend having that much time in there, or is it something that you would prefer of like the moment I know what's going on, try to get this fixed? This job would be a lot easier if I could predict the future, but I can't. And so these recommendations are based off of risk. So if you have a hernia and it causes zero pain all the time, I can tell you from a statistical standpoint that it's very unlikely to result in a strangulated hernia that gets fixed in the middle of the night as an emergency. Because almost all hernias are going to start causing mild to moderate symptoms first before they move on to those really catastrophic symptoms. So if you're a person with a completely asymptomatic hernia, I'd tell you, okay, fix it now, fix it later. It might be 6 months or 6 years from now. I don't know. I can't predict the future, but you can safely watch it, continue doing all the same physical activity,
that you want to do. You're working out, continue going to work. No, I'm not going to give you a work release. Live life. It's fine. If it starts hurting, come back to me. We'll talk about fixing it. If it's a hernia that's escalating in pain and problems, those people I'm going to say, look, your hernia is more likely to cause a incarceration or strangulation. I can't predict when it's going to be. I can just tell you that it's more likely to predict to happen. So for that, I tell people, look, the sooner you get this fixed in a reasonable amount of time, you can control when you do it, where you do it, how it's done, plan your downtime, plan your life around this. But if you wait until the day when you have to get this fixed, I can't predict that day. And that might be right, the day before your wedding, the day before a non-refundable, Hawaii vacation. I don't know, but that I've seen all that too, and that happens. So, when people have a symptomatic hernia, there is a relative unpredictable nature to these sometimes. So, for those people, I counsel them on that and let them understand what we're dealing with, so that they can kind of take their chance that they want to take. But the advice I give people for a symptomatic hernia is an elective repair. So most people follow that. Some people will come back like a year later and say, yeah, you were right, Dr. Schilling. I need this fixed now. I'm ready to go. So,
Well, then it seems like the recovery time too, because I know that's what Nick is in right now, and having like a physical job. And at the time when my husband, he had a physical job too, it seems like a balancing act of like, how do you know when you're ready? And that's kind of where you've been, right, Nick, of figuring out how to play out the recovery?
Generally, what I hear is 4 to 6 weeks of very little activity. I could still walk. I think that was one of the recommendations that they said was actually good for it, was continuing to walk, which I did quite a bit of. And I recommend to anybody listening that is going to have to go through this to do so, because it does increase the blood flow, which helps the tissue repair. I've heard 4 to 6. My doctor recommended 6 weeks of not lifting any more than 15 to 20 pounds is what was recommended for me.
Which is not fun for a personal trainer.
No. Although I can tell you that my clients saw a good amount of gains in that time because they were lifting all of their own weights.
Yeah.
And, I think the question mark becomes after that 6 week period, because I think we're all so different. And, maybe my strength level at that period of time after 6 weeks could be different from somebody else's. Just trying to figure out what is right for you. I started, what I would consider slow for myself, and I would recommend any of my clients do the same. But I can definitely say that there's probably people out there that get that 6 week clearing and they're like, all right, well, let's go back to, heavy deadlifts. Let's go back to, throwing boxes around at work or whatever it is. And I guess that's the hard part for me to know, is I feel like it's more intuitive. I don't know if you have anything on that, doctor.
Yeah. Would you recommend that, like, once you actually clear somebody, does clearance mean go ham?
Right. No, that's a great question. I spent a lot of time talking about this because just as how unique people are and how their presentations with hernia are, so is it how the operation affects a person's life. I mean, a personal trainer has a different lifestyle than an accountant, different job demands and things like that. So, my recommendations are pretty similar. When I'm doing a very straightforward robotic inguinal hernia surgery, typically it's minimal narcotics and encourage walking and ambulation for the first 2 weeks. After 2 weeks, someone's coming back to me in the office, and as long as everything looks good and feels fine, at 2 weeks, I start increasing physical activity. I tell people basically there's no restrictions at 2 weeks, but that doesn't mean jumping back into everything they were doing the day before their hernia repair. What that means, if someone's got an exercise routine, we'll talk about it, what they're doing, what types of exercises they're doing, and I'll basically tell them to break their workout routine into thirds and take 3 or 4 weeks at slowly ramping up or conditioning their bodies back up to what their ideal workout routine would be. And that's to get the person going through the motions, using their core the way they want to, and really trying to build back some of the strength they may have lost on their downtime. And as long as everything looks good and feels fine, people do very well with that. I'm not really worried about a lot of hernia problems after someone resumes normal physical activity, except in the case of extremes like, doing like extreme heavy lifting or extremely physically demanding work at a job. But I am worried about somebody injuring themselves, pulling a groin muscle, spraining an abdominal muscle, twisting an ankle, busting a knee, because they're still healing from the hernia surgery. If they, step funny or move funny and twist in a way, they could get some other type of injury that would be a setback during their recovery phase. So, I really empower and encourage people to be active during the recovery phase, but it comes with a lot of, be careful this and listen to your body that type information, so that somebody knows what they're doing and kind of is better in tune with their body while they recover.
Do you feel like most people are itching to be active again, or are they like, oh, I'm using this excuse and I'm milking it and I'm just going to chill out and everybody's going to do stuff for me?
Most people want to be active again.
Okay.
And that's really where I've seen like the advantages of robotic hernia surgery more than every other type of method to repair hernia. It's in the hernia world amongst surgeons, it is a very hotly contested debate about what the best hernia repairs are. And it comes down to a lot of things, the type of hernia you're fixing, the type of patient you have, the type of facility you're doing it in, what the surgeon is good at doing. I mean, there are so many other factors. So in general, do what you do best. But for me, doing this robotic repair has given me the ability to really shorten the downtime for patients without sacrificing the integrity of the repair or risking any other further injuries. So for me, it is my go-to repair. And people are doing physical activity, 2 weeks from surgery most often with very little to any discomfort. But their body's still healing, so they do accept some pain and some discomfort while they're healing. So, it's all about, talking to people, listening to them, managing their expectations of what hernia surgery is going to be about, and then following up on that. After 6 to 8 weeks, generally the hernia repair has healed enough where you wouldn't really expect much pain at all at that point in time. But there's about a 10%, 5 to 10% chance of having chronic groin pain after a hernia operation. So, you do a perfect hernia operation, the patient recovers great, but 2 or 3 months down the road, they still have some groin pain.
All right.
And that could be not a hernia, but related to the repair and inflammation on the surrounding nerves of the groin. So that could be another issue. And it could go from a very mild, easily ignored pain to a very severe, life-changing type pain that needs to be treated. So there's a lot of nuances like that come about when you do a lot of hernia repairs. So I've seen it all when it comes to that.
Are you having any chronic groin pain, Nick?
Well, I wouldn't consider it pain, but I do feel like ever since, it's been about 3 months now, ever since I've started, working out again and kind of pushing myself a little bit more, whenever I go to that next step, whenever I, lift a little bit heavier or do a motion that I haven't done in a while, I notice that there's a little bit of pressure in that area and the area where it occurred. I don't know if that's typical to what you see.
Or is that something he should push past?
Yeah, I mean, it could be a mild nerve problem from, residual inflammation caused by having a piece of mesh in your groin like that's near the muscles and the nerves. And so it's not so much of a problem if it's there, it's how is it affecting you? Is it preventing you from doing things? And that's really where the art of managing this comes into play is, if this is a pain that's easily ignored and it's just kind of an annoying, nagging type situation periodically, then it's really nothing to worry about. But if it really and sincerely impacts someone, whether it, they can't perform functions that they want to do, or, they have to take pain medication to get relief, or it wakes them up at night, then we go down the road of trying to diagnose and manage chronic groin pain after hernia repair. It is not an insignificant occurrence. I mean, the rates go from 5 to 15%, depending on what studies you read. And it can go from everything as simple as just ignoring it to treating it with medication or doing nerve block medication or nerve ablations. Sometimes people require surgery to remove mesh or tacks that were used during procedures. Other times, and these are extreme moments, and to give you an example, I've been operating on hernias for about, I don't know, 15 years, and I've never had to do this, but it's called a triple neurectomy, where you actually go in and you remove the nerve roots of 3 main nerves that go to the groin. And it basically makes your entire groin on that side numb, but it takes care of the pain. That is surgery reserved for disabling groin pain, like severe groin pain after hernia operation. And I haven't, knock on wood, seen that or had to do it, but that's how far that spectrum could go for people. But having a little bit of a sensation of fullness or a little sore, sometimes with movement, is not uncommon.
So that's not something that he should just like double check with his doctor with? You're just feeling pressure, not pain, right?
Yeah, I mean, when it comes down, it's just like pressure. It almost feels similar to the beginning stages of when I had it the first time, like very, very light, just kind of like if there was somebody inside of my body pushing a finger outside, that's kind of how I describe it. That's kind of what I feel.
See, that would worry me, because I'm like, do I need to go to the doctor again, or am I just in my own head? Like, that's how I would feel.
And that's the common thing I think most patients would say is like, is something wrong? Mm-hmm. Because they've been down this road before. Something was wrong, it was fixed, and now you feel this symptom that feels very similar. And for me, and what I encourage my patients to do is I want my patients to come back to me. If they have a pain, a sensation, or lump or bump or something that doesn't feel right, and they've had hernia surgery by me, I definitely encourage them to come back and see me, 3 months, 6 months, a year out, whenever, because the best way to figure out what it is and how to treat it is to talk to an experienced hernia surgeon and get a thorough hernia exam by an experienced hernia surgeon. And then you can open up the can of worms, like, do you need an X-ray or an ultrasound or a CAT scan to help better learn how to manage and diagnose this problem? And that way, if you have, if Nick was my patient, he had that symptom, and I talked to him, examined him, and so we might decide to do nothing, and he goes back to normal activities, and but maybe 6 months down the road he has another issue or another problem. He comes back, and then over time we maybe develop the fact that this guy's got chronic groin pain, and maybe it's maybe it's affecting his activities. And so then that would kind of lead us into the discussion about, should we treat this? And if we do treat it, how do we treat it? And that sort of thing. So it's really, it can be, a longer relationship if someone has those types of issues. But I would always encourage people to go back to their hernia surgeon or a hernia expert to talk about it, because, I think having information is key, so that you're not just sitting there wondering, is this a problem? Isn't it a problem? Is it? I don't know. Like, what should I do? Because that can be alleviated by seeking out a healthcare professional. It might not make the pain go away, but at least that it's nothing you can worry about, and you can go back and, do physical activity without really worrying about it.
Well, it seems like that would make that more challenging with kids, because multiple men I know that have had hernia surgery also had one when they were a kid. So, I mean, that's got to be harder, of like, you're dealing with a 7-year-old, and, their pain levels. At what point do you go to the doctor or not?
Yeah. Well, so pediatric hernias are much different than adult hernias. Pediatric hernias are fixed. Pediatric hernia will, escape through the cracks from time to time. But, if it's almost a different problem altogether.
Okay.
When you're talking about a pediatric hernia versus an adult inguinal hernia, because adult inguinal hernias, most of them are repaired with mesh, whereas a pediatric hernia, none of them are repaired with mesh. The recurrence rate on a pediatric hernia is very low. So, I'll see adult patients, and I'll say, yeah, I had one when I was a kid. I don't remember anything. Mom said I had it done, whatever. I mean, technically it is a recurrent hernia, but it is a much different operation. It's much more like a brand new hernia like a first-time hernia operation, than someone like an adult, like, yeah, I had one fixed with mesh when I was 20, now I'm 40 and I have a recurrence. That is a recurrent hernia. That is sometimes, most of the time, more technically challenging or difficult, a different discussion about risks, benefits, expectations afterwards, things like that. Versus when you're talking about someone who had one as a little kid, those patients do very well. It's almost like they just have a primary first-time hernia.
Okay. So would you have any advice for anyone that's, listening, or maybe has somebody in their life where they're like, at what point do you seek out the doctor? Or you're like, I think especially for women too, you're talking about like around the belly button, where I think a lot of women, not to separate men and women, but it's just like, I got other stuff to worry about. I'm going to push past this. Maybe this is just something else. Like at what point are you like, no, I need to go to a doctor?
Yeah. So, I think medical doctors and, are great at, when you go for your history and physical and your checkup, they do a full exam on you, they're looking for hernias, and things like that. And, they might ask you like, hey, does this bother you? No. Okay, fine. Ignore it. But then that's kind of all the information you get. Because, as a medical doctor, they know they know what a hernia is. They know, who to send it to, if it's a problem or if the patient wants to be seen. But, they're not going to give a lot of this other information about what do hernia repairs look like? What is the surgery like? What's the recovery like? What's the downtime like? They'll kind of give some basic information, but maybe not enough to make really informed decisions about when to get surgery or if surgery is the right option. So what I would say is anybody who thinks if they have a hernia and they're wondering, when should I see a surgeon? They should probably just see a surgeon. Because going to see a surgeon, it does not obligate you to get surgery ever. It's simply a chance to sit down, have a discussion about possible symptoms, do a really thorough physical exam, and come up with a strategy and a plan, whether that's just expectant management, which means we're just going to watch, wait, and see. And now you know me and I know you, and you can call me when you're having a problem. That's great. We got a plan. Or maybe it's something like, yeah, I didn't know I could get this done. Let's go do it now. And my life is so much better, but they didn't know. And so I think a lot of what a surgeon provides up front is information. And then that information can just lead to a bunch of guidance about long-term what I should do. And people are often surprised, like, yeah, I didn't know all of this that you're telling me now. I just thought it was, just come in, get an operation, and go home. But, there's so many different facets to this problem that I think, when people find a surgeon and talk to them, and many hernia surgeons accept most surgeons accept referrals from primary care docs, but a lot of surgeons, myself included, accept self referrals for things like this. So you don't necessarily need a referral to see a hernia surgeon to discuss symptoms and everything. And I think that information more than anything is key to starting that process off. So
how would somebody contact you directly? Just send you an email?
Yeah, they can send me an email, call my office, go to our website, Christ Hospital. Those are the easiest ways. I mean, we accept self-referrals all the time, and, happy to see patients that way. People go to the ER for the first time. That's a common entry point for people into the primary care world. And while I don't advocate that, I mean, it's certainly how things are done often too. But we're all over the place and I accept those referrals. And if all I do is dispense a bunch of information out to people and help clarify what their issues are and what they need to be looking out for in the future, that's great.
Awesome. Well, so if anybody's listening to this and is questioning whether or not maybe they're dealing with this, then I can put all the links in the show notes to go to the Christ Hospital and come see you and get it figured out.
Yeah, absolutely.
Awesome. Well, Dr. John Schilling, thank you so much for joining me.
Oh, you're very welcome, Amanda. Thank you for having me.
Thanks, Doc.
AmandaValentineBites.com